If they can whisper with grandma, with a teacher, then have them whisper and just leverage that as much as possible.
So all of those nitty gritties make the difference between success and not. So we have to set it up so it's all there. It's like setting the table.
And start off with sounds. This is a little bit like your ritual speech.
Welcome back to another episode of the Unspoken Words Podcast, a selected mutism podcast by the Smart Center, produced and published by New Edition Productions. This episode features a discussion between Dr. E and licensed psychologist Ruth Perednik on real-world exposures and their significance in the treatment of your selectively mute child. Ruth is a British-Israeli psychologist who heads the Selective Mutism Treatment Center in Jerusalem. For over 3 decades, she has developed an innovative cognitive behavioral treatment approach for children and teens with SM, achieving excellent intervention results. Ruth offers online courses for parents and therapists, provides worldwide training for mental health professionals, and conducts intensive treatments globally while lecturing in English, Spanish, and Hebrew. Her work began over 3 decades ago when her trilingual son suffered from the then almost unknown condition of selective mutism. In this episode, Dr. E and Ruth discuss why children don't progress while practicing skills only in the treatment setting, how to continue therapy at home, how to get buy-in from teachers and school staff, and more. Before we get started, if you have any questions on anything you hear in today's episode between Dr. E and Ruth, please head to selectivemutismcenter.org/ask Dr. E and enter your question. We read all of your submissions and we do our best to answer them on podcast episodes, blog posts, and on social media. And speaking of social media, for the best of this episode and every episode of Unspoken Words, make sure you're following the podcast on Instagram and YouTube. We are at UnspokenWords_podcast on Instagram and Unspoken Words Podcast by Dr. E on YouTube. All right. Without further ado, please enjoy the latest episode of the Unspoken Words Podcast.
Hi, everyone. It's Dr. E. Before we get started with today's episode, I'm so excited to announce that our popular Selective Mutism in the School virtual conference is now available as a self-paced online course. The conference dives into how to assess the mute child, testing for common comorbidities, and proven strategies and interventions to support students with SM within the school. And of course, we dive into accommodations and interventions such as 504s and IEPs. The course offers 5.5 continuing education credits from most professionals. So parents, share this opportunity with your child's school. To sign up, just head to our website or check the description in this podcast episode. Together, we can create a world where every child has a voice. Now, enjoy the episode. Hello, Ruth.
Hello, it's great to see you.
It is so great to see you, and I follow your work, so we are very honored to have you here, and we have so many listeners from all over the world. I think last count was 107 countries plus.
Oh, my goodness, really? Wow.
Yeah. So we have so many listeners following the Unspoken Words podcast. So we are so excited to have you. And I want to jump right in because there's so much to talk about.
There is.
I mean, the first thing I would like to say is both of us came about this interest, profession, expertise, passion, obsession via our children.
All of the above. Absolutely. Firstly, it's an honor to be here. Really. You've been so influential in how I treat selective mutism, and it's a small group of people, and that's a wonderful group to be a part of. But yeah, I came to this as you did, as a young psychologist, and my son was trilingual. We moved from Argentina to Israel. He spoke Hebrew, English, and Spanish, and he was a very chatty boy at home, and he stopped talking when he went to kindergarten. And this was in 1990. There were still dinosaurs on the roaming the country in those days. And selective mutism just was not a known entity. So and I intuitively then, I got all of these wrong diagnoses, very alarming, very upsetting. And I knew who my son was. And so just intuitively, I realized that the way to help him is this bridge from home to school, to kindergarten, and to help him bring himself from home to the kindergarten. And so I went into the kindergarten, my husband went into the kindergarten, and we tried to educate the teachers, even though we didn't really know what we were doing particularly. But it was very intuitive, and it remains really the essence of my feeling of how to treat selective mutism, that bridge from home to school. And as you said, it's my passion, it's your passion, it's really in our veins, isn't it? It's just our life's work.
I mean, it really is. It's beyond, like, when people say things like, your work, or when are you going to retire, or, I'm like, wait, I love what I do. And, things are changing, and things are evolving, but I still love what I do. I'm still passionate about this topic. I'm still always wanting to write and speak to people. And I feel like when you were speaking, it could have been me, with my daughter, because as a physician, I was taught to treat the person, not a symptom. That's what I went to med school. That was the first thing we learned about. Like, you have a fever, you have a fever. Why do you have a fever? So that has been the hallmark. And then learning, you brought up the bridge from home to school, the bridge from home to restaurants and stores, wherever it might be, but also the social communication bridge for us, because I feel like anyone that focuses just on talking without understanding this child and who they are and why they may not be talking, to me, are missing the boat.
Yeah.
And so I love your work. I love that we both have, I think anyone that's successful with this population has to have similarities. The words we use to describe it may be different. How we come about it initially may sound a bit different, but there's so many similarities. And when I do these podcasts with different experts and different people in the field, there's so many similarities, but yet there's differences. And I think some treatments are a little bit more effective for some, and others. I will say that when you see it as from a person standpoint, like you said, I think you hit almost all populations of SM, because not all children are timid. Not all children just need to be exposed to verbalization. It's understanding why they're not. And I love, love, love when you talk about why the clinic isn't enough. And that is one of the hallmarks of what we tell families. Like, yeah, you can come and bring your child, or we can do telehealth, but it's what we learn, right? Experts in those sessions
Right.
that then guide you out of the sessions.
Right. I think that the two gestures that can kind of summarize treating selective mutism, and I agree, there's so much similarity between how different practitioners are working with selective mutism, because it works, because that is evidence-based, that works. But I think there's the integrative, there's the parents, teachers, therapist, or key worker, and getting the teachers to help, getting the parents to help. And then there's the bridge from home to school, the social communications bridge. But I think that in order to help a child, being in the clinic is just not enough, because that is the essence of selective mutism. A child will talk in the clinic, a child will be chatty and involved in the clinic, and then you go to school, or you go to grandparents, or you go to the store, and he or she is not going to talk. So that is why working in the clinic alone, without either feelers out, training, working in conjunction with teachers and with parents, or going into the school, which is what I love to do the best, just isn't enough. And, I'm sure that you, like me, every day get clients who come in and say, yeah, we've been to psychotherapy for 4 years. Sometimes you
Yep.
get teens who've been to so many
Oh,
different kinds of therapy, and none of them have taken it out of the setting. And that's not
100%.
acceptable.
That is 100%. I would say on a daily basis, we receive calls from families, and at least one or two of them say, and I'd say the far majority is, yes, my child was in the clinic, eventually spoke to the clinician, which in my opinion shouldn't take that long, but sometimes it does. But they weren't given strategies, interventions, accountable goals. Sometimes you can see it as homework. I see it as helping you unlearn a conditioned behavior, knowing what to do, but these accountable kind of take home goals where they write it in, they know they either on their phone or on a hard copy, where they are unlearning. And we're going to talk about that bridge a bit, because for us, it's like, okay, you do this at home, you transition, whatever that skill may be, into that environment, and you see where can they achieve it. And that's your starting point. So if
Right.
they can achieve it alone with the parent in the school, the verbalization with the right accommodations and the right skills. Because I do want to say, one of the things I think that stands out, and as we talk about this moving it, I do want to ask you, so for these children that have speech and language issues are on the autism spectrum, I'm amazed how many kids we see with ASD, with
Mhm.
neurodivergence, that have
Mhm.
ADHD, that have processing issues, that have sensory processing. Wouldn't you agree you have to understand those kids in order to adapt the treatment?
You absolutely do. And my original research, which was 25 years ago, no, it was 20 years ago, apologies, I divided in a very rough way between children who have simple SM, which is it's a phobia of speech, which might be because of their disposition. Obviously, always nature and nurture, what I've been through in life, what kind of kindergarten, perhaps geographical moves, perhaps language difficulties. And then there are children who have so many different comorbidities or
Yep.
a comorbidity. But in all of these cases, I advocate for treating selective mutism because so that the child can have access to the help that they need in whatever else is going on in their life. But, I think one of the important points is that you've got to see each child as his unique person with his strength, with his challenges, with whatever comorbidities there may be, and adjust, fine tune the treatment in order to fit the individual child, and
I
never
love it. I
consider it
wish
a cookbook. Never, never.
I love that. I feel like that's going to be one of our like statements on our YouTube is like you saying that, because if I had a glass of wine, and it's a little early here to have a glass of wine or a glass of champagne, because I truly do love seeing you. And I remember talking to Brandon going, you have to reach out to Ruth, is that clinking of it, because that is exactly right. Every child is unique. Every family is unique because integrating the family, every school system has
Absolutely.
their right. And it's about really understanding that. And I don't get the come on in, let's get you to talk attitude, because to me, you're missing the boat. And so for us, we do the selective mutism eval that starts to really see what is this individual's individuality.
Exactly. And one of the beautiful things about the integrative treatment is that you get to know the parents, you get to know the teacher. You're not seeing, whether you're going to the school or not, you're not seeing the child kind of in a separate from everything else that goes on in his life. And you can never understand a child when you take them separately from their family, from their school, from their culture. So it is so important to have all of that in mind.
So that's another thing. So the first thing we talked about is taking it from the clinic and out. And that's with accountable goals, hard copies, knowing what, when, and where, how to do it, training the parents. Just a day ago, we got a message from a family. I forget exactly where they live. It was out west. And she said, we've been in treatment for 2 years and we loved our therapist, but honestly, he's made minimal progress, but he's talking to her and all the office staff, but I've never been taught what to do. And so I leave that session where I'm usually in the waiting area with my child, and I leave, come back the following week, and I don't know what to do outside that office. And
Mhm.
I'm like, well, my staff, but that is what needs to be done. So we certainly can work with you. We can educate your therapist, but you've got to take what they know works out and about into that world and to train you just
Mhm.
even how they talk to their children, right? The can you, will you
Mhm.
need to, you should language. We need to help them be more direct and positive and upbeat. And how do you bring them into social communication? So you practice that in the office with
Mhm.
the parents, with
Mhm.
the child, and then you go out and you work on it in the way the clinician recommends. So what
Right.
are your thoughts on that?
So absolutely, the parents have to be trained, the teachers have to be trained. It's a combination of materials and videos, but there is no way to do it without. I mean, some parents do, but on the whole, to do it without the connection with somebody who really understands and can help the parents learn how to speak to their child, how to do exposure in the school with grandparents outside their home, inside their home if children don't talk when they have visitors. So It's vital. And you know what I feel is a really good recipe for success. Firstly, the integrative treatment, but also the training parents, having them learn, having teachers learn and key workers learn, but then ongoing guidance. It usually isn't enough to explain, to put the whole program in front of a parent and say, okay, this is what's going to happen and this is what's going to happen next. And it never works out as you imagine. It might work out better. It might take longer. You may have to change the direction in some way, but that is really a good combination, to have the training, to have the learning, how to speak to the child, how to do exposures, how to talk to the school, and then having that ongoing guidance.
100%. Exactly. And so you get that initial consult to really learn, get them started. And your case and mine, we probably write them these reports that tell them the game plan, but it's tweaking, tweaking, tweaking.
It
Each
is.
visit is tweaking, tweaking, tweaking.
It
So
is.
right? So they send, at least us, the update forms, the follow-up forms, the school vow forms, they keep tweaking based on progress. But one
Right.
of the things I'd love to do with you is, because we, talk about, the clinic isn't enough. Let's give our listeners some examples. You give some examples. I'll give some examples. Because one of the things listeners like is, all right, you're telling us it's not in the clinic and
Mhm.
you're telling us you got to bridge it, but tell me some examples of how you do that. And the same with, how do we train a parent? And we can both give examples. So
Mhm.
you can go first. I can go first.
Oh, whatever you say.
Yeah, go ahead. Like, let's give examples to our listeners about some of the things you do in terms of taking it from the clinic that you learn about them
Mhm.
out about into a specific setting.
So I will always give parents homework, tasks, specific interventions that they can do from the first session. And I'll tell you a couple of things that I nearly always say. One is invite friends home. And when you invite friends home, make sure that you understand how to do gradual exposure. Perhaps your child won't talk initially to the friend, but he might listen to some videos. He might talk to you. You might be able to play a game and there's a bit of whispering. Maybe your child, and this relates to seeing each child as a unique person with preferences, with things they don't like. Perhaps jumping on a trampoline in the garden, that's what relaxes the child. And just have a session where you're jumping on the trampoline and then you're playing a game that requires speech, that the child can talk to you, the parent, or to a sibling, and the friend is there. That's one example of taking the understanding from the clinic to the home. And yeah, and another thing that I always tell parents straight away is to video and record. If the child is not very opposed to it, we do it all the time. We have our phones on us all the time, and it's something people do. And when you have videos of your child in their comfort zone, in their home, where they are talking, playing, interacting to whatever level that they do at home, and you can bring that video into a place where they don't talk, that's a fabulous first exposure of bringing their voice. Of course, you have to do it with caution. You have to do it in a way that it's not going to be too much, that it's going to slightly raise the roof of their comfort zone, so that they'll be able to do it, and they will have done something that perhaps they have never done, to have their voice heard with grandparents, with a teacher. So those are two examples that I nearly always will.
So do you tell the child that? Because what I do is, I don't do that like all the time. So, like, for example, when I'm thinking about the social communication bridge, I use augmentative devices as a transitional stage. But what if the child is very resistant? How do you deal with that? Because to me, I'm always about, I mean, if they're 3 or 4, maybe it's a bit like different, but even then, like, what do you do if a child is like, no, I'm not going to take my voice? Then I guess you just don't do it.
On the whole, you don't do it. If you do it in a playful way, and one of the techniques is sensitization, is desensitization. It's small steps towards speech, and which is exposure or systematic desensitization. And you can usually find a smaller step to begin with when there is resistance. Sometimes there is, and then you just, we're not going to use recordings. But what I usually tell parents is just video and look at it together and get them used to being videoed, being heard with mom, with dad, with grandma, if the child is comfortable with grandma. And then once they have got used to being videoed, being heard, then you can take it one step further. So the small steps approach is such a correct approach, but sometimes you can't do it. Sometimes that there is the resistance, and then you just go on to a different strategy. Yeah.
And I think you're describing a lot of what we do with the bridge, because one of the things we do is the SCI, the social communication anxiety inventory. I want to know their baseline, their highest stage in a setting. So we want to know their highest stage, nonverbal, transitional, either using an intermediary, turning to their parents' sounds or augmentative devices, or verbal, quiet one or two words, or initiative, elaborative, and expressive. So what we do is we want to know their highest stage that they can do. And that's where we start. Then you're right. We break it up. So that's the similarity that we're talking about, of how we have to start where they can, because you want them to feel empowered. You want them to feel they can do it, rather than, I always say, meet them where they're at, right? It's pretty much what you're saying too.
Right. If they can whisper with grandma, with a teacher, then have them whisper and just leverage that as much as possible. Yeah. And then perhaps be a little bit more distant, and they're whispering in a loud whisper. Yeah. And, and take it from there. And I think that there are so many games also. I love games.
Games are the best.
Games that will just be distracting, and you can start off in a whisper, but then you really want to win. So you say taco or cat, and so that is also a really good strategy with friends, with grandparents. That is very, very helpful in terms of.
Yeah. And for young children, that's so great, right? It's also a distraction, as we know. So they're focusing on the game, putting a little competition. So they may want to win, and they forget themselves, right?
Right.
I think the hard part, and I'm sure you see this, which I'm sure some of our listeners, because we get all ages, we get children, teens, and adults, is that the older they get, the more cognitive they are, the more avoidant they tend to be, because either they totally don't know how, meaning in those environments, they're so stuck, or they've been in a treatment where they didn't meet them where they were. It was very speech-based before they were ready, and they're avoidant. They're not trusting the process. They're more anxious. And it's unfortunate, but that's what we get a lot. We see a lot of families. If you're going to travel from California to PA and you want to come, you've exhausted usually your local resources, right? Wherever it might be. Right. And so at this point, some of these children are just so scared and avoidant because we didn't meet them where they were. Yes. So I love that you do that as well. Like, really meet them where they are. And that, like, the bridge, like, for me, that is my, I don't know. I always look at the bridge, and then the children make their bridges, Ruth, and they know where they're at. So when you're working with these kids, I love these games. What are some of your favorite games? I just would love to hear.
So I have a list. I think some games are made for children with selective mutism. Taco, cat, goat.
I don't know that. What is that?
Quite a new game. It's my go-to. Game. Dixit, Taboo. Obviously, it has to be Goldfish, Red Light, Green Light. Yeah, games that require running around. I'm going to show you one of my main tools.
Okay.
For games, which is these big balloons. Yeah, and this is an example, and this can be with children of all ages, also with teens. With teens, obviously, the C of the cognitive behavioral is more pronounced. And with younger kids, it's more behavioral. It's just playing these games, which are taking them step by step to being more relaxed, more able to communicate. And I think also, I know that you use the communication bridge. I do with older children, with teens. With younger children, I put a very big emphasis on the behavioral, that the child's friend comes home and they talk at home, and then they meet in the park and play the same games. But I'll tell you about this balloon game, because this has worked with many teenagers, that, and there you've got the cognitive where you're planning it and you know this is going to happen. But this is something, it's kind of like a clothes hanger where you're hanging the progress in communication on these games. So I have one girl, delightful girl who I worked with, a 14, 15-year-old who'd been to so many therapies and it hadn't worked. And then she called the therapy the beach ball therapy, because she would, and this is an example both of the integrative therapy and of the desensitization, the exposure. So she had this kind of paradigm. And of course, I would discuss it with her and she would plan it and we would update the teacher and the parents. And we would use a lot of cognitive behavioral techniques, also the mindfulness and the meditation, but those techniques don't talk to everybody, even older teens. So this was the paradigm. She would send a recording to a friend. And this is quite, these elements happen with many teens with me. She'd send a recording to a friend, or the friend would send a recording to her on her phone with a question. She would answer the question. And that would be the first time that her voice would be heard by the friend without her present. Then she would come to her house whenever possible, and they would listen to it together. And then we did sliding in with a teacher. So she was already talking to the teacher, a small, delightful school. And then in the school, the teacher, together with the child with whom she hadn't talked, they would listen to the recordings and then throw the ball one to another and start off with sounds. This is a little bit like your ritual speech.
Yeah, like the fun use of sounds.
Right.
Sounds. Okay. The ritual sound approach is a very ritualistic process, but it could be a step in it.
Right.
So it sounds like it's fun use of sounds, which I'm loving. So transitional stage. Go ahead. I'm loving this.
Right. And then throwing the ball. I love these big balls because you have to kind of loosen up and find the ball. And that's, that's very conducive to feeling more relaxed. Then starting off with sounds like and moving on to animal sounds. So it might be a mouse, it might be a snake, it might be a dog or a lion, which is rare. So you're not actually projecting your voice. And then moving on to words. And each person who throws the ball, the teacher would say, okay, now we're going to say ruff, ruff, ruff. Now we're going to say me. Now we're going to say you. And that would be, and then moving on to categories. So that is a combination of a game.
Yep.
But you're going step by step, starting off by sharing. She would share her voice, then the friend coming home, and then moving it to the school with a key word.
Yeah, exactly. That it's very, it's very similar to some of the children we work with that they're kind of stuck in the nonverbal. You kind of figure out where they can do it, shaping sounds into words. And the interesting part, when you mentioned the RSA, I just want to say, we have teens that are so stuck, they're speech phobic, they're professional mimes, even adults where they are so mute in a setting. And that shaping sounds, taking a deep breath in, taking a deep breath out, pushing air through their teeth, so they're seeing it from more of a cognitive, becomes a way they do it. So someone's like, oh, my 15-year-old's not going to do sounds. Meanwhile, they've been mute for years, but they come in, we do that, we explain, look, we know you know your sounds, but because we're stuck here, and we help them with the bridge. So it sounds like we do the same sort of thing. We do that too. Like at camp, when we're shaping sounds with the little guys and they're making sounds. And again, animal sounds, the first letter, the second letter, that's a wonderful strategy for little kids too, because they're just having fun. Right. And I love the movement part.
Yeah.
The way you're describing with the ball. I love it because they're distracted, they're moving, and it just all works. It's such a great tool.
And it's also, you can always break it down to a smaller step. And I think you have that in the ritual sound approach. And it's also part of this kind of game that, okay, if they're not managing to vocalize, so you take it back a step and you do more sounds. And that is very empowering because the teen or the child is managing. They are managing to succeed in this game. And they can then hopefully take it one step further the next time, or even in the same session.
Yeah, no, I think I love that. And I think we talk about parents. I often say, don't wait, facilitate. So some parents will wait for their children to make the change. I tell teachers, don't wait, facilitate. Because if you wait, like the child isn't going to walk in and go, all right, here are the strategies you need to use on me, and write it down and hand it to them. They're not going to do that. So we have to train
Right.
all of the adults in their life to facilitate. And like you said, the key workers, the OT, we all have to be on the same page. And it does get challenging in families where parents are divorced and
Mhm.
one child, you know what I mean? They may be going through a divorce
Mhm.
and that's hard because if one parent's doing it and another parent's not, the child meets inconsistency.
Right, right. That is tricky. And also you have different levels of the degree to which teachers will cooperate and will, yeah, or a key worker in the school will actually implement all of these kinds of steps and tools. When there is excellent cooperation between parents, teachers, and therapists, that is for me such a promising state of affairs that is so conducive to change. That leverages everything that each person is doing,
Yep.
what the teacher's doing, what the parents doing, what the key worker is doing. And I think that one of the things that is wonderful about Zoom and that we can have telehealth
Yep.
is that you can meet regularly when there is cooperation with the teacher and the parent and the key worker.
Yep.
And then you're saying, okay, I have invited so and so to my house, the child, and my child has been comfortable with this friend and is talking. So could the key worker in the school take my child with this friend, and my child is comfortable doing recordings and has done lots of recordings, so could the teacher listen to these recordings? So when you have that cooperation and you have each corner of this triangle working together and fine tuning, that is conducive to change.
It's interesting how you keep going like this with the triangle, and I think about holding hands. So
Ah,
you see it as that, and I
like
see
it.
it.
I
It's the
like
same
it.
thing. It's the same thing, but like everyone's together. So like you, educating the school is so critical, and we saw that in our original study that when we were working with the families, the kids were making great progress, right? Out and about, friends were coming, but the
Mhm,
school was lagging because we need to train the school. And as soon as we added that school training, you see the boost. And it's like you said, it's so beautiful when as a team, we're all working together. And when the child is able developmentally, cognitively to understand, they realize we're meeting them where they're at and we're helping them. And everyone's working together. It's not you need to do this, you should do this if you do that. It's more like, hey, here's where we're at. We're going to have so and so over. Then we're going to meet on the playground. Then we're going to meet in the resource room and we check it off, check it off, check it off. And it's so
mhm,
positive that those walls that so many of these kids have built up start to really come down because they realize, hey, I can do this. And we
mhm.
see this all the time where you just have to meet them where they're at. And like you said, what if they're nonverbal? Okay, that's where we start. It's not like, oh my God, they didn't talk, so they failed. It's more like that's their starting point.
Yeah, and I think I love what you said about facilitating because um,
Don't rate, facilitate.
because so many teens and children have told me after therapy that I was stuck in this place. I wanted to talk, I
Yeah.
couldn't. And I needed my teacher to come up to me one on one and implement these small steps. And I needed my parents to implement these small steps and my therapist. And I managed to come out of this kind of pit that I'd fallen into and I could not do it by myself. So it isn't usually enough to talk to the child, to practice skills. It has to be facilitated in the child's real life.
But talk to me about the sliding in method and like how you would define that. I mean, because everyone has a version of that, and I'm sure there's a lot of similarities between a lot of us, but you specifically say the sliding in method. So just what's Ruth's sliding in method?
So, firstly, it is a magical moment of change in so many cases. I have witnessed sliding in where grandparents have heard their grandchild for the first time, tears and just such a beautiful, magical moment of change. Aunts, friends, and it happens. And once it happens, it's a fact. The child has spoken to the grandma or to the best friend, and it really is magic, and it is a method that works, and that's so every therapist should be using sliding in on their own sliding in, many different versions, and it can be implemented at the home and in therapy and in school. I'll tell you my sliding in for home because
Yes.
I love the home school treatment, which is what I do in my clinic when I'm not doing telehealth, that a therapist will come to the home, do sliding in at home, help the child talk to him or her at home, and then go into the school, help her talk to the therapist in school, and then generalize. And so it's all based on sliding in. The at home, I basically talk about 4 stages. And of course, you meet the child where they are. Some children will whisper, will talk to a stranger who comes into the home, but many won't. And so having the therapist have a cup of tea with mom and be there while the child is playing, is talking, is hopefully, and this requires preparation, it requires work with the parents, that they will set up the situation, that there will be something fun that the child will be doing. With a younger child, I'll often do that home sliding in without preparing the child, so that we're gaining a jump start, we're gaining a head start, that after 4 sessions, usually 2 to 4 sessions, the child will be talking to the therapist. Obviously, with older children, with teens, you prepare them. But even so, I like to do that. That mom or dad are in the kitchen having a cup of tea, and the child is playing, talking, listening to videos of themselves. And then gradually, the therapist will move into the same room, and dad or aunt or older sister will continue playing, and then will take a few cards from Dixit or from Guess Who or Go Fish and join in a game, and then actually be talking directly to the child. This can happen in 1 session, it can happen in 4 sessions. And as I said, it's not a cookbook. You have to go with what the child likes, with how the child responds, and modify. So also with sliding in, there is such room for creativity with thinking of what will be the most correct for this child. What does he like doing? Does he like drawing? Does he like playing football? I had one child where all of the sliding in, this was this year with a therapist of mine, was through football. Once we discovered that kicking the ball to another child and saying Spurs, Tottenham, kicking and saying something while you're kicking, that just loosened him up, and he could do it. So we went just with football with this specific child. But if you take the sliding in to the school, and let's say the therapist or the key worker, he has already done sliding in at home, so the child talks at home. And then it's a combination of exposure and sliding in, because first you want the child to talk to the therapist again at home. At school, a variable has changed. It's now at school. You can't take it for granted that the child who talks at home is going to talk in school. But if you do the exposure that you've done at home, which could be listening to a recording, playing broken telephone, playing the balloon game, playing Go Fish, playing Taco Cat, then very often over 1 or 2 sessions, the child will regain the ability that he had at home to speak in a therapy room in the school. And then sliding in with other children, with staff members. And it is always, I like the holding hands. That's going to be a new gesture for me. Yeah. Yeah. So, hopefully the parents will have invited a child, a friend home, and done exposure at home. And then the therapist will, or the key worker will come to the school, help the child speak in school, and then do sliding in with a child with whom the selectively mute child has already spoken at home, if that's possible, but even not, just perhaps playing with this balloon game, perhaps playing broken telephone, listening to recordings, and gradually incorporating more children, more staff members into that school session.
Hey listeners, we'll get back to the episode in a second. I want to tell you about Communicamp, our popular 3+ day intensive group treatment and all-day parent education and support program designed to help parents, children, and teens overcome selective mutism, social anxiety, and extreme shyness. Over 3+ action-packed days, your child or teen will engage in immersive activities guided by expert clinicians that build confidence and communication skills in a supportive, fun, and collaborative environment. Spaces are limited and spots book up fast. To learn more, please find Communicamp in this episode's description or head to communicamp.org and complete our interest form, and our team will be in touch. Let's help your child or teen find their voice at Communicamp. Let's get back to the episode. The teacher, knowing the child may now speak to a specific, let's say it's a 7 or 8-year-old, and the child now is speaking to his or her friend. The teacher now knows that. So during class, the child can be paired and grouped with that same child. And then in addition, the teacher can say, do you want red, or if the child isn't speaking to the teacher yet, do you want red or blue? Avoiding eye contact. No. Answer, avoid red or blue. Tell Rebecca. And now your child already talked to that child. It has a verbal intermediary. Where prior to this, so you moved it into the school. Now you've got a verbal intermediary. So at least we've got more communication and progression across the social communication bridge. So yeah, I mean, it's always interesting for me to hear people that, we don't work every day together, obviously, but when you work with this population, you realize over the many years you and I've worked with this population, what works and what doesn't work. And, making it fun for these young children and really involving them, demystifying this, I call it A&A. Acknowledge that this is scary or hard and assess it. It can be like a 5 out of 5 or a 2 out of 2, a 2 out of 5 is easier. And so I trust their feelings a lot. So that seemed easier this time. Maybe last time, remember, so we get them to really get their feelings, and that helps them gain that control. Because I always think, and I was wondering your thoughts on this, to me, so much of this is them feeling out of control. And one of the reasons I love the bridge and the cognitive aspect of the bridge, even for little guys, they know where they're at. I feel like that gives them control where they normally feel out of control. So I know I can do this with this friend in this place.
Well, I have to say that with younger children, I often do not involve them in building the intervention, in building the desensitization, and it happens to them. They know that I'm there in order to help them speak more comfortably. But the reason that I often do that with younger children is because it works. It works faster.
Were you talking younger, like 3, 4? Because a 7-year-old will know.
I think a 7-year-old will know. I would say until around 7. Yes, until around 7.
Because the little guys, you're right. Like you make it fun and they do it. I always say the younger they are, the easier. It's less years they condition. So we don't involve them as much. But sometimes giving them the words. So if let's say as they get older, you're involving them. So you're telling them who they're working with, kind of like who's going to be sitting with them. But then what you're discussing is silent goals. We talk about that, where we as teachers, we as parents set up the world for them. Right. And the active goals, as you're saying, are a little more reserved as the kids get older. So that's completely makes sense. And that's why it's important that as adults, not only do we don't wait, facilitate, right? But we set the world up so that they can be successful.
Oh, I love that. Setting the world up. That is what needs to happen.
Yeah.
To whatever degree they are involved in being part of building the plan, of saying how they feel, from almost zero with younger children to being really partners with teens or with older children. Of course, we are leading and we know what we want. And we also know what is most likely to work.
Right. So we set the world up. And parents don't know that often. They don't know how to do that. Like teachers, they'll buddy them, right? Like here's what I say. The buddy process, small groups in the room, small groups out of the room, which we all know. But what are they doing in the small groups? How are they questioning? Where are they questioning? Who are they included when they question?
Mhm.
What are they using? So all of those nitty gritties make the difference between success and not. So we have to set it up so it's all there. It's like setting the table. We know,
Well, and one of the exposures that I do in schools with teachers, this is one of my go-to for children up to the age of about 8, I would say, is a 4-week plan. I like to, one of my jobs when talking to teachers, I'm sure it's the same with you, is to explain to them how significant their help will be,
oh,
how they
100%.
can be such a therapeutic agent of change, where they will be changing this child's life for the better. And that is the basis of successful learning, successful integration socially also. So, but then I like to give them a very, very specific and short-term intervention to do that. I'm
Yeah,
not asking them the rest of the year, give this child 5
5
minutes
bullet
a
points.
day.
Yeah.
Exactly,
Yep.
exactly,
And then you tweak. And
exactly.
then you tweak. I always go like this. You got to,
I'm gonna take that. I'm gonna
yeah,
use.
we're learning all these hand motions, right? I got this and got, the hand holding. We've got the tweak, tweak, tweak. Sometimes I compare it to a tree. You've got the general strategies and interventions that work for many at
Mhm,
first, but then
mhm,
it's tweaking it. You're going off on a branch and then off on a
mhm,
branch, off on a,
mhm,
and that's why it's so hard when a family calls and says, I need an IEP or I just need my kid to talk. Give me
mhm,
strategies. It's like, wait,
mhm,
who is your child? Because what works for your child may not work for the other child. And also taking into account, like, I'm going to give you an example. We have a lot of kids in our practice with comorbidities, and I think we attract that population
mhm,
because of that whole person where
mhm,
exposures aren't always enough and behavior change. So you have a child with autism and they're 10 years old and they're in school. It's not just the talking, it's the social puzzle that's
yes.
so hard, and having them navigate conversations,
Mhm,
how to start the action plan, who's going to be there, what can be said, what is your answer, like
mhm,
they need more of that and they need more activity to be a focus rather than the nuances of reading a face in conversation. So it's like
mhm,
the same with ADHD and the processing and not being able to keep up with a conversation or expressive language. So they can respond, but putting their thoughts together to have a give, take, back, forth. So knowing this, Ruth, is so important because that's where you adapt the treatment for what strategies may work better for that child versus another child that doesn't have those challenges.
absolutely. In the initial consultation, you've got to get the whole picture because there are often things that need to be done both in the treatment that we are going to, the treatment plan that we're going to build. And again, tweak, tweak, tweak. You're building a treatment plan and then you're changing
Tweet,
it.
tweet, tweet.
Yes, yes. This could be a great dance. But you also have to think about what are their other needs. Perhaps they need to be learning to speak the language, the
Wow.
spoken language. And until then, how are you going to help them talk to friends when they're not talking the same language? Perhaps they have pronunciation difficulties. Perhaps they have a generalized social anxiety, and perhaps they have a lag in social skills and they need to learn those social skills. So you've got to get the whole picture. You've got to see simultaneously what can the parents be doing? How can I incorporate these specific challenges that this particular child has into my treatment plan? You can't have a successful treatment plan without knowing the child, without knowing his likes and dislikes, his preferences, his strengths, and perhaps there are comorbidities or challenges. So, yeah, I would like to say one other point that treating, I feel, and this is to do with also being accountable. And this is really a pet subject of mine, that therapists, psychologists have to be accountable. They have to see that what they're doing is helping. And treating selective mutism is hard work. And it's hard work for the therapist who is tweaking all the time. I'm not saying, okay, you're going to come and play with me and that's going to really help you. I'm working with a teacher, I'm working with a key worker, I'm working with the parents. It's hard work, but it's also hard work for the parents, and
Yes.
it's hard work for the teachers. I mean, it's reasonably hard work for the teachers. It's not the end of the world. It's doable. But this takes me back to your original question. Why does it have to affect the child's real life? And the only way it can work is when there is hard work, which is guided by the therapist of all of these different significant potential therapeutic agents of change in the child's real life. So it's hard work. It's not, as therapists, we need to think, okay, what's worked? What hasn't worked in our original plan? How has the child responded in school, at home, in the store with grandma? Let's think what worked. Let's think what didn't work, and let's plan so that we will have constant improvement. That's what we want. Of course, it's not always going to work, but that is what we're planning. We're not sitting on our laurels and saying, this is working well, let's leave it at that.
I love it. That's exact. It's interesting. And you and I met, you and I have known each other for a long time, and we always got along. And I'm always thinking, like, if you were here, I was there, we'd probably work together, because there's so many things like that are so many similarities. And it stems from our passion and trying to understand these kids and really help them, like the satisfaction you get. But every session starts with, hey, what's working well? What's a challenge? And why is that a challenge? And backing up into what may have caused more of a challenge, and how can you tweak that so that next time it's successful, and you find out, oh, we didn't pre-plan, or we went during a really crowded time to Target, which is a store.
Yeah.
And it's like, we didn't have a friend. They paired with the wrong child. Like, you start to realize what worked and what didn't. And I think the hardest thing is parents, that consistency of knowing what, when, and how to do things, and really helping them unlearn their conditioned behaviors. Because when you went like this with the triangle, I think of the SM triangle. I think of it as the person at the top the child doesn't talk to. The one side is the parent or someone the child does talk, and then the child. And so many times the parent will tell them what you want to eat, tell them what we're looking for in a store, say hi to your friend or say hi to the neighbor, but the child isn't even engaging yet and can't do it. They don't know what, how, and when to do that. And then you've got the parent that speaks for them, and enables lack of social communication. So the key is to integrate that by how the parent questions the child. So I always say a choice is always easy, with the right answer second as a starting point, and having visuals. Visuals can be for everything. So that minimizes the need to think and process. So you've got all that going. So every time you go like that, I'm thinking of my SM triangle.
I like it. That's
we're all about the emotions today. But I was going to say that what's working well and what's not is so, so critical. And I don't know how you are, but for me, when I see a child, so I have a monthly program. We have weekly psychotherapy in our office, but I do what we call the monthly SCAP program. And one of the things we do is parents will fill out a parent follow-up form. The school will fill out their form. So before they see me, Ruth, I need to know what's working well and what's not, so I can focus on that. Because then I start the session with, let's go over the things that are happening. And I don't know, because for me, I want that time to be so focused on tweaking the process. But it's, yes, I teach this all the time to my students, is you need to know what's working and what's not. And when something's not, there's a reason. Always, always a reason.
Yes.
Sometimes it's just the parents misunderstanding what to do. And you have to educate them again and teach them that skill.
Yes. And I love the accountability because of writing it down. Also for a teacher, if a teacher writes, and it has to be minimal, they're not going to fill out a long form, but what have they done? And details are so important. For example, you send a video of a young child, and the teacher is supposed to listen to it one-on-one with the child. And that will be kind of the top of their comfort zone, but not bombastic, something that has never happened, that will be so hard for them to manage. And then the teacher takes the video and puts it on a huge screen, and the whole class listens to the recording, and the child was not ready for that. And that wasn't what the teacher was, what was explained to the teacher. And that can be a traumatic experience for a child when it's just too much. So I think that's also part of the training, that the details, the gradual steps, but also listening to your recommending.
Listen and learn. Look and learn. That's another one. LLL. Look, listen, and learn. Because the kids tell us everything.
Yes. Yes.
They tell us everything without them telling us anything.
Yes.
Just how they respond, their body language when they're, you know what I mean? So yes, you're right. I love it. I love it. That's such a similarity. So you mentioned the word trauma, and sometimes people are like, does SM start from trauma? The typical trauma of abuse, we don't see that, but unless it's an abrupt change, right? Or traumatic mutism.
It's rare. That's very rare.
Very, very rare. But trauma can be what you described.
For-
Trauma can, right?
Absolutely. For a sensitive child, I hear so often that a child will say, I didn't know that the teacher was there and I was talking to my mum. And then she came up and said, oh, wonderful to hear you speak. And I didn't want, I wasn't ready for that. Or the example that I gave of having a video suddenly on a large projector when I wasn't ready. And of course, trauma is also being shouted at, being even vicarious trauma, that when there is an atmosphere of being sensitive to the children.
Absolutely. And I'm going to say something and, might come with resistance to this, but to me, trauma is trying to get a kid to talk when they're not ready. When they're, that's trauma. And we see it every day in the office where they were asked and told, you need to talk. I had a teacher withhold a cookie during snack time because the child didn't talk, because the goal from that particular therapist, not sure why, is your child she needs to say what cookie she wants. If not, she doesn't get, that's trauma, Ruth.
That's trauma. I have a worse example, which is flooding, which is when I was in university in England in, I don't know when, in the 70s, this was something that was considered that you could do, but it absolutely isn't. I had a case of a kindergarten teacher who said, you're not going home until you've said, thank you for the chocolate. And the child did say in the end, thank you for the chocolate. He was desperate to go home, and then he had school phobia, and he refused to go back the next day.
So a message to parents from what you just said is, yes, you can force a kid to talk sometimes. Here's the question to a parent listening, because that's the majority of our listeners.
Mm-hmm.
We do have treatment providers too, I have to say, and we have older individuals, but by far the majority are parents. How is your child reacting after these goals that you're doing or trying to do? Are they upbeat? Are they positive? Are they more confident? Are they excited? Are they looking like, or are they avoidant, more anxious, resistant, behavioral difficulties? That is such $1 million question, because what you were saying with, you need to say this, we hear this still to this day, which baffles my mind. The child's need to talk, got to talk, you have to talk. You're going to have friends if you talk. If you don't tell your teacher, they're not going to know what you know. We talk about talking, but we meet them where they're at. It's not like we don't talk about talking, but we know it's hard. Mm-hmm. And here's where we're going to start. And they rate their feelings. They get it. But how, as a parent, all the listeners, how is your child reacting after you're implementing strategies?
Right. Does she feel good about herself? Does she feel that was a bit hard? But yeah, I did it. I feel good about myself. Or does she lie down on the floor and cry? That is never good. That
you're not willing to go back to that therapist, or not wanting to go to school, or not wanting to go to a restaurant or a store now. If your child is doing that, you need to stop and figure it out.
I say that so often. I had a parent come in last week whose child has been in therapy for a year, cries before every therapy session. That cannot be. And don't be the therapist. It has to be that the child is feeling empowered. Perhaps it's quite a difficult. It might have some difficulty. There might be habituation, that you get used to this fact that the teachers heard me, and that was quite hard. I didn't feel all that comfortable, but I did it and I feel good about it. If that's not the case, then you have to go back to the drawing board and tweak.
And I often say comfort precedes communication, comfort and connection. Let's add that. Mm-hmm. Comfort and think of it as a cake that you're baking, and the icing is the comfort, connecting kids, putting it all together. If you don't have comfort in a setting, a connection to someone, if you don't have that baseline, you're in trouble, because kids are not going to make these huge leaps without that sense of connection and comfort level.
Right. And that's one of the first things that I tell a teacher, that you can establish a relationship with this child, even if he doesn't talk to you. Right. You can show your interest in what they're doing without putting them in the limelight, which might be too much for them. But yeah, that's a very colorful picture. You cleared up all those toys. That's helpful. You can see them. They're not invisible. That's the
Right.
first, they're not transparent. That's the first stage of having connection. And sometimes teachers are scared of doing this because they feel that the vibes that I'm getting from the child is stay away. I don't feel comfortable with you. And that is the teacher's job, is to find a way of approaching the child and having him feel comfortable. And nearly always it is possible to do when there is goodwill and understanding of the teacher. And the same goes for grandma, the same goes for
Yep.
any uncles, people with whom the child doesn't feel comfortable. The first stage is feeling comfortable. One of the important things in feeling comfortable is not to have a barrage of questions. Tell me what what your best friend's called. How old are you now? Not to have that barrage of questions, but to engage with a child on a level at which he feels comfortable. That's the starting
Meeting that
point.
child where they are. So I think in summary, this has been a great episode. We talked about why the clinic isn't enough and having accountable goals, having ways for that we train and bridging to these other environments in a very stepwise manner, many times using specific skills and strategies that are particular to that individual's needs, whatever they may be, and accounting for their whys, accounting for their baseline stage, educating the team. Your triangle, my hand in hand, teachers, parents, key workers, the speech and language pathologist, grandma, grandpa, Aunt Bertha. They all need to understand
They
so that
do.
everyone is meeting that child where they're at. And we talked about the sliding in method, which is beautiful and it's needed. And that goes along with your bridge because you're sliding in using your bridge
Right, right.
and bridging it together. And then, we talked about everything, the critical need of training. We always say an initial training, we usually say an hour training, and then every 6 to 8 weeks for 30 minutes to tweak, 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 because you
I
can't give the school a barrel of things. They need to have 5 or 6 bullet points to really work on.
Mhm. And the integrative bit of
Yes.
it, of having a combination of and actually getting together. And it's so much easier on Zoom now that you can get
Yep.
together with a teacher. It doesn't need to be long. But what have you been doing? What has worked?
Yep.
Let's tweak that. Let's make sure that what you're going to do for the next few weeks is something that is going to be appropriate and is going to empower the child and is not going to engender a sense of failure, which children with selective mutism feel so frequently. They're requested to do something and they're
Yep.
not doing. The same with parents. What are they doing? What are they doing at home? What are they doing outside the home? And is it working? And is it empowering?
Yeah, no, you brought up that sense of failure. That's what children describe, and they'll draw that or the sense of shame. And so the key is what is, that's important. If your child is feeling that way, that's not the confidence that's going to fuel progression of communication.
Right.
Comfort, connection, confidence building, independence fuels communication and to become a confident social verbal communicator.
Yes, it's exactly that. Yeah. I we agree. We just agree on everything.
We agree. And we always did like have that similarity of meeting them where they're at. And it's,
Mhm.
whether you're calling it one thing or I'm calling it something else, it's really important to really meet that child where they're at and understand their unique needs and have everybody integrated and educating the school. You have to educate everyone. We have that document about my child. Look, we can't meet with everyone. Sometimes you meet with extended family, and we
Mhm.
always want to meet with the school, but that about my child worksheet where you describe your child, give it to people. Some children write their own. Here's
Mhm.
ways you could help me. It's amazing how when children get involved, how empowered they feel by being in control.
Yeah. What do I dislike about family gatherings? What
Yes.
helps me feel comfortable in family gatherings? And then the extended family can learn from that. Yeah, that is a great sense of control and empowerment.
It's been wonderful.
It has been so good to talk to you. And, I do want to say one thing, that I do feel that the movement over the last 20 years has been to ensuring that the child's real life is impacted, and of getting that help in the school, in the kindergarten, at home, with friends, and just taking all of the environments of the child's real life and making sure that strategies and tools are implemented gradually. So it is, meeting them when they're at, and then building on that. And tweaking, yes. And just ensuring that progress is happening.
Ruth, how can our listeners get information on you, your practice? Share with our listeners the best way to reach you.
So I have a website, which is selective-mutism.org. And on that website, you can see all of my social media. I'm just putting up something new for the Southern Hemisphere about summer, about how to help your child progress during the summer, how to start off on how to plan with a teacher, with the new staff. And it's a window of opportunity. So I love working with parents and giving them resources so that they can use this summer, not just as downtime, but as part of that hard work. Of course, it should also be fun and relaxing and recharging batteries, but helping your child take steps, and specifically with a transition starting from a better place. So basically my website, and if you just look up my name, you'll see also my social media. And and it's my passion, like it is yours, sharing with parents. And we see it from the parents' perspective just as much as from the therapist's perspective, perhaps more.
No, absolutely. And so we will let you know when the episode is done. It'll go up. We're going to share this, and hopefully many of our listeners will go to your website, learn from you, get great resources. And I thank you so much, Ruth.
It has been so good to be with you, and keep up the amazing work that you do.
You too. Thank you, Ruth.
Bye-bye.
Bye. Thank you for listening to Unspoken Words, a Selective Mutism podcast hosted by me, Dr. E, and the Smart Center. This episode and all episodes of Unspoken Words is produced by New Edition Productions. Don't forget to submit any questions you have from today's episode using our Ask Dr. E form on our website. Just head to selectivemutismcenter.org/ask-DRE. I'd love to answer your question in a future episode or blog post. Remember, for the best of this episode and every episode of Unspoken Words, please follow the podcast on Instagram and YouTube. We are at Unspoken Words _podcast on Instagram and Unspoken Words by DRE on YouTube. Or join our newsletter for additional SM content. We release new episodes every other Monday at 6 a.m. Eastern Standard Time. We'll see you next time.